咁啦，我哋今日第二個環節嘅講師係楊慧博士。楊博士 Ella 係曾經擔任香港理工大學康復治療科學系物理治療教授，而家係大學嘅兼任教授。佢嘅專業經驗係運動創傷及術後嘅康復治療。佢喺北京奧運同埋廣州亞運擔任國家女子曲棍球隊主治物理治療師，其後更加被任命為國家奧運代表隊運動醫療專家組嘅成員，參與倫敦同埋里約奧運。而家將時間交俾 Ella 同我哋分享 Rehabilitation of Shoulders Injuries， 有請。
Good morning, everyone. I'd like to say thank you to the Olympic Academy for inviting me to this particular seminar. I believe that because the organization has sent us the participants list, and of those, I already knew that there are, and Simon has already asked, a lot are physio students, but they are amongst the others, coaches and people that work at the NSA, that because of the diverse audience, sometimes it's difficult to try to pitch to the right level, or maybe that is appropriate or relevant to where you are working. So I have made some, put some thoughts into preparing for this particular lecture, and I hope that the physio students will be able to have something to take home, and also for the NSA members, that they are something that you can take back as well. So my topic is on rehabilitation of shoulder injuries. I have worked at PolyU for quite a long time, and left 4 years ago and started my own clinic. So again, that has given me a lot of good perspective into looking at the practical side of the rehabilitation for athletes and for some people that are not doing many sports. Okay, so the objective of this particular lecture, I would like to first consider looking at some of the anatomical considerations relating to shoulder injuries. So for those who might not be so familiar, so an introduction about those, particularly on 3 areas, looking at the rotator cuff musculature, just try to highlight the importance of what rotator cuff muscles do, because they are very small muscles, and why are we so? Why do we have to consider that so importantly? And then the second part is on the scapular muscles, the scapular musculature. There are a lot of those, and of which there are some which are important to the understanding of the rehabilitation and what muscles are more of a priority. The third part is on core and lower body function. Is it relevant to people with shoulder dysfunction? We'll try to explore and look at some of the literature that talk about that. And after that, I will look at rotator cuff related shoulder pain. In the past, in the literature, the pathologies that people quote in terms of shoulder pain, there are many, things like tendinopathy, rotator cuff tears, but now they're all grouped under, in the recent literature, they talk about this using an umbrella term called rotator cuff related shoulder pain, rather than in a separate entities, and I will tell you the reason why that is the case. I have a couple of case studies which I like to show you, one of a shoulder dislocation and the other is of a person who had a rotator cuff tear and how they went through rehabilitation and be able to return to their sports successfully. So hopefully that would give you some understanding about the use of exercise to address people with strength, with mobility, stability deficits. This particular image is very old, but I like that a lot because it tells about the way how the shoulder moves So if you have a sea lion holding onto a ball and then the arm as the distal part of the movement, where you're able to handle that part and be able to do the mobility work or be able to handle with control, you need a rather stable base. So the body itself of the sea lion depicts the scapular part where it provides a platform to allow a stable base, and then you have the shallow ball and socket for the shoulder joint, so you'll be able to move the arm freely and be able to control and balance it properly. So the shoulder joint is quite a the joint is very different from the hip joint. Hip joint is very deep ball and socket joint, but rather the shoulder has a lot more mobility when compared with the hip joint. So when you have a lot of mobility, you need to sacrifice sometimes the stability for it. So how do you manage the mobility that you're able to control the mobile segments of the body, of the shoulder while you maintain the stability? Within the shoulder, there are what we call the dynamic restraints, which are the muscles that help to hold and put the shoulder in a good position to allow movements to occur. And then you have static restraints, and usually these static restraints are where people get injured. So static restraints, by that I mean structures like the ligaments, the labrum, etc., etc. So a lot of people get injured on the static restraints. So static restraints, by all means, they're not strong to allow the shoulder to move with power. It's the dynamic restraints, which are the muscles that you need to control the shoulder. When we talk about the shoulder joint, it's not really a shoulder joint. It really is a shoulder complex. If you look at this particular diagram, I think these are just revisions for the physio students. There are a lot of joints involved. So glenohumeral joint is the actual shoulder joint, and then you have the acromiohumeral joint joining in the front. Let me see, I can't see. Is this there? Yeah, acromiohumeral joint in the front, and then you've got the acromioclavicular joint, which is on the other side, in here, acromioclavicular joint, and then you've got the sternum, and then you have the scapulothoracic joint. It's not exactly a joint, but it's just directly laying across. So all these joints, if you have dysfunction in any one of those, it can cause problem to the actual shoulder joint proper. And then neighboring joints, your cervical spine, your thoracic spine, also can affect the way how the shoulder moves as well. So a typical example will be if you have a patient or an athlete with thoracic kyphosis, where they're very fixed with the thorax, they can't move their thorax, they can't actually lift their arm properly. That's because the shoulder is fixed against the thorax, you can't move properly. So sometimes when we are looking at athletes, or maybe on the kind of sports that they are doing, they're prone to getting some joints tighter than the other. Then if they do have a shoulder problem, it may not necessarily be the glenohumeral joint that you need to look at first. You may want to look at other parts of the joints, whether there are some restriction or stiffness in around the area, that perhaps once you address those, you may be able to free up the shoulder joint better. Okay? So the first one we want to look at is the rotator cuff musculature. These are the innermost muscle within the shoulder. This is looking in the front. So this is your acromioclavicular joint. So we have a few muscles in here. You have the subscapularis, and then the teres minor over here. And then at the back, you have the supraspinatus, and then the infraspinatus underneath. So these are four muscles that are closest to the shoulder joint. What's most important is these four muscles all attached to the greater tuberosity of the joint, where it's blended together with the capsule. Usually, the small muscles that are closest to the body, like the small muscles within your back, you know how people talk about training for core muscles for the back. So you are also training the most innermost of the muscles. What's most important is the ones that are closest to the joint are the ones that stabilize the joint. So as such, the rehabilitation principles of this is that if you do have people suffering from shoulder dysfunction and you're wanting to go through an exercise rehabilitation, then perhaps these are the first muscles that you need to consider first as your first priority. So stabilize it first so that these muscles can help to put the shoulder into a good position with the good stabilization before you train the bigger muscles on the outside. So these muscles all have their own different action. Supraspinatus abduction, moving in this direction. Infraspinatus teres minor, moving into an external rotation, and then you have subscapularis, which is moving into internal rotation. They all have different function, but most important, as far as the rotator cuff muscles are concerned, they work together to stabilize the shoulder. Because of the way how the muscles are arranged, when they work together, they will keep the humeral head, which is the humerus, to press against the socket during movement. So it provides that stabilization role. If these muscles are weak or fatigued, the shoulder joint will come up and move upwards, slipping upwards into the acromion. That means it got hit against this area where people call the subacromial impingement, 即係嗰啲撞擊症. And then every time when you lift your arm, then you have pain in the shoulder. So therefore, these muscles are important, more so about the stabilization instead of just the function purely for abduction. Because, for instance, if the supraspinatus is only working on abduction, there are more powerful muscles that work. Your deltoid works in abduction as well. They are much more powerful. But why do we need that little muscle to work on abduction? That's because they have a stabilization role. And also, thinking about rotator cuff, these are small muscles. They're not powerful muscles. They're used to provide stabilization, and it's an endurance thing. You need this muscle to work very hard, to work to stabilize the shoulder. They're not for strength. They're not purely just for strength. Rather, they're more needing for endurance type purpose. So that's so much so about the rotator cuff. The next group of muscles, which is a big group, are the scapular muscles. There are a lot of them. Okay, primarily there are some which are very important for shoulder movements. There are three muscles that are very important. One is the lower trapezius muscle. The second is the serratus anterior, which is not shown in here. Okay, which is not shown in here. All right, and the rhomboids. These are very important. And then I'll talk about those in a minute. So these muscles around the scapula, the shoulder blade, they help to control this. So any muscles that are close to the scapula and attached to the scapula, they obviously have an influence to the shoulder blade. Therefore, some getting tight, some getting weak, which may change the position how the scapular platform is placed during movement. So for instance, if we look at the upper muscles, if you have tight upper trapezius or levator scapulae muscles, if this becomes tight, the shoulder moves up, and therefore it changes the position and the biomechanics of the movement. In the front, not in the front. So these are the line of pull of the muscles. So the lower trap down here, the serratus in here, and the rhomboids. These are very important muscles during the movement of the shoulder joint, because when you move your arm up, this shoulder blade needs to go upwardly, needs to move upwardly rotated to allow the arm to move in a smooth action. If these are not working properly and not in coordination, it can cause disruption to the scapulohumeral rhythm. So much so of those relating to strength. If you have tight levator scapulae or upper trap, as I mentioned before, it can also change the pull or the movement of the scapula. In the front, very powerful muscles in the front, they also change the scapula because of the attachment. Particularly the pectoralis minor, because it attaches up here. So this is the shoulder blade. It attaches up the top here. If this muscle is tight, it pulls the scapula to the front. So sometimes you may see some athletes where in the shoulder blade, there's a bit of a tilt. That's because one of the possible reasons may be because the pectoralis minor is tight and causing change to the scapular muscle. Okay, so this is showing how the importance of the two muscles that I have just mentioned as the upward rotators of the scapula. So a lot of the time, people with shoulder dysfunction, these might be the muscles that you want to train and work on at the initial phase of the shoulder rehabilitation. Because the lower part of the trapezius and the serratus, it helps to move, upwardly rotate the scapula when it moves up. Okay? Downward rotators are the other ones which we say that they're not so good, because if these muscles, pec minor, levator scap, if they get tight, they do not allow the upward rotation to occur. So a term that we use called scapular dyskinesis. Kinesis basically is movement. So it's a dysfunction in the movement. It's commonly associated with all types of shoulder pathology, basically. It can be the cause, but it can be also a result of painful shoulder and the scapula is not moving properly. If the position and the motion of the scapula are altered, it would impair the shoulder function. So it not changes only the static position, it also changes the dynamic position as well. So if you find that in your athletes, you may need to address this. So let me show you what it looks like. Okay, we can look at this. I don't know if it's bright enough to see. So we're looking at both shoulders. If we look at the right compared to the left, you can first look at the right side first. Okay, so you can see how the scapula, the shoulder blade, is moving quite smoothly as it goes up. Let's look at that again. Okay, so the right side, you can see that the shoulder blade is moving upwards as you abduct the arm. Whereas if we look at the left side, when the arm brings up, not much rotation, and during the eccentric phase, when it comes down, the shoulder blade lost control completely. So therefore, these muscles around here obviously are not working properly, and then it changes the whole dynamic of this. Obviously, this is doing a very controlled motion, and this is what we do as physios in a clinic. You examine the patients. But if you are working with athletes, when they need to do their activity using their shoulder at high speed, at a complex motion, then this will cause a problem. Okay? So not so much only about rehabilitation when the athletes got injured, but also as a prevention thing as well too. So you may need to consider those in your athletes, whether the shoulder has got the musculature around the shoulder blade to be able to perform the action smoothly. So some of the, we've already looked at or talked about those. If your scapula tilt forwards, if the pec minor is tight, coming forward, okay? If there's internally rotated, and if there's a lack of upward rotation, it causes problem. What does it do? If there's increase in anterior tilt, it then presses on the labrum as the arm go into external rotation and abduction, which you need to do a lot with throwing sports, right? And then it may lead to problem with the labrum. Labrum 即係個魚唇個雙邊嗰度啦。Okay, if you have a decrease in upward rotation，就好似頭先嗰個 slide 啦。The athlete cannot move the arm smoothly into an upward rotation. It increases the chance of impingement. If there's an increase in internal rotation, it causes also pressure into internal impingement. Impingement喺邊度咧？ Okay, so we're looking at this as an image. This is the front of the body. So this is the collarbone. This is your shoulder joint. This is the scapula at the back. So each time when the arm is not rotated properly, in between the collarbone, the clavicle, and the shoulder, down here, the supraspinatus muscle runs underneath, and there is a bursa underneath as well too. So if it keeps riding upwards, then it causes pressure in here, and sooner or later it can develop a pain in here. 就係頭先講個撞擊症啊 where every time when you lift your arm up, it causes pain. Okay, so this we must address. So hopefully you don't want this to happen, because once this happens, you already have inflammation and irritation. It will be very hard. You need to treat it symptomatically first before you can address the other things. So you certainly do not want that to happen in your athlete, and doing some preventative exercises to prevent that from happening. Okay, there was one period when I in China when I worked with the throwing group, people playing javelin. We talked about and I presented this as well to the group, where we talk about is core and lower body function important in shoulder dysfunction. There have been some research that look at this. There's a guy called Ben Kibler, who's an orthopedic surgeon, and he works with several physios, and they look at how changes, weakness or maybe stiffness of the body, lower body, causes pain to shoulder, which can contribute to shoulder dysfunction. So when you do overhead activities or throwing patterns, it requires quite a lot of precise interaction of the whole kinetic chain. So a lot of the power comes from the leg and the trunk. At least 50% of the ball velocity comes from the leg and the trunk. The lower extremity is vital in the production for the force during throwing. Obviously, your core is important, to stabilize and being the key in the whole kinetic chain concept. So if there's any deficits in the strength, the endurance, or the neuromuscular control of the lower extremity, it can have direct impact through the upper extremity and leading to poor production in mechanics. Poor production in mechanics meaning that some muscles are overworked, and then it may cause issues. So what are the alterations? So these are some practical examples I think may be useful for the coaches, and for the physio students also may be useful. For instance, if you have trunk weakness, if your core is not strong, the stability is lost. So you're requiring other muscles to work a lot harder. If there's tightness, flexion, extension, or lateral flexion, if you throw, if this is very tight, you can't go through. This has already limited your movement. So all you have to do is to make your shoulder works further back, harder to be able to produce the force. Okay, so trunk weakness, trunk tightness may be an issue that you need to consider for your athlete. Non-dominant leg, hip, internal, external rotation tightness. When you turn, when you do your movement, if this other leg, this is the leg that's doing the throwing, if there's a lot of hip tightness in here, this hip cannot turn, then all you have to do, you compensate with something else from the top of the dominant side to produce the movement. So contralateral side, non-dominant side, hip internal, external rotation tightness, you may want to check if the hip mobility is an issue on the non-dominant side. Single leg stability deficits. In your throwing, somehow you need to eventually finish off single leg. So if the stance phase or the squat phase, if there's a stability issues, meaning that if your glute med is not strong, sometimes that can also cause problem because your shoulder may need to work harder. If you have prior injuries to the hip, knee, ankle, and muscles, you may need to consider whether those can be a contributing factor to a person presenting to you with shoulder dysfunction. Okay, so much so about the discussion about some of the anatomical considerations or biomechanical considerations relating to shoulder dysfunction. So let me recap again. Rotator cuff muscles stabilization, very important to keep the head against the socket and prevent it from overriding during movement. The second part is the scapular muscles, which provide a stable platform to allow the glenohumeral joint, the shoulder joints, to be able to move properly through a proper rhythm and proper movement. So some muscles that are important, they are prone to getting weak, or you want to train it, lower trapezius, serratus anterior, rhomboid muscle. Muscles that are prone to getting tight, your pec minor muscles, your upper trap, levator scapulae muscles, you may need to check those. The third part is the core and lower body function. So core muscle weakness or maybe a range of movement deficit, your non-dominant leg hip tightness, or the gluteus medius muscle strength or prior injuries. Those things may be a contributing factor to somebody having shoulder dysfunction. So you may want to look at those in your athletes. Okay, so next thing I wanted to look at now as a pathology, okay, is people getting pain. Okay, so just now we're talking just about the musculature. People getting pain. A term being used now, rather than talking about a specific injury in the literature, most of the time people now use the term rotator cuff-related shoulder pain. So basically, pain arising from the group of muscles which are the rotator cuff, which we've talked about, and hence the term rotator cuff. In 70% of all the shoulder pain, the rotator cuff muscle is involved. It is an umbrella term now used to describe shoulder pain. Often structures around the shoulders can be involved. So some of the pathology which we used in the past, subacromial impingement which we talk about, people with rotator cuff tendinopathy, or maybe an older term you heard, tendinitis, people with rotator cuff tear, is now all umbrella under this particular term. The reason being that because we have very powerful MRIs, right? So everything that you see is in minute details to the part, which particular part is injured. I mean, I'm not saying that those are wrong, but studies have shown that there is a poor relationship between the level of pain and disability with the degree of structural deficits detected with imaging. Sometimes you may see images being very poor, and yet the level of pain and disability may not directly associate. A most common example is age-related degenerative rotator cuff tear. So rotator cuff tear, non-traumatic, but age-related. Those people walk around, they don't have pain in the shoulder. They don't necessarily have any disability at all, even though the image may show, the MRI images may show that there is a tear in their rotator cuff. So if we're just purely looking at the pathology, it's very difficult to determine the relevance to pain, as the structural changes seen on the scan can also be seen in pain-free population. So what do we do? Okay, so surely there must be some way that we need to consider, how do we work on these people that always come in with the shoulder pain. Normally, where do they feel their pain? Usually this is the way how they say, broadly around the deltoid, upper arm area. And then it's all activity related. At rest, they're not in pain. It's usually worse with overhead activities, and particularly with external rotation movements, right? Every time when they rotate, okay? And with activity, it hurts. The mechanics very complicated because the shoulder structures are very close to each other. So what are pain, what do pain-free movements rely on? We already talked about the importance of rotator cuff. Firstly, very strong rotator cuff muscles to protect the joint. Second, good control of the glenohumeral joints. joint, and then the third one is stability. I'm coming to more awareness about shoulder stability being an issue, because when we think about shoulder stability, the joint is very shallow. So it requires a coordination of the muscles around it to be able to carry out the function properly. The muscles need to work in coordination. So some of the good ways that you can train stability using perturbation is almost like when you have an ankle sprain, you do some wobble board movements to get co-contraction of the muscles. Similarly, you do similar kind of exercise using this strategy for the shoulder, which makes a difference in getting the muscles to work with each other. If you have weakness of the rotator cuff, muscle overwork, loss of control. If there's lack of control of the glenohumeral joint, the structures like the supraspinatus may be impinged in the area, leading to pain and inflammation. So just now I have talked about these structures which are involved, impinged under the subacromial space, the rotator cuff muscle tendon irritated, or maybe a tear. What did the literature say about these things? There are a lot of supporting evidence recently that talk about how to manage subacromial impingement. Subacromial impingement, definitely conservative management. I mean, the surgical management may include you open up the space more, etc. But definitely not the way how you manage subacromial impingement. Conservative management is definitely the first hand of working with subacromial impingement. And of these, exercise therapy is the first line treatment to improve pain, mobility, and function. And generally, the suggested exercise, the way to do the exercise, being specific, but low intensity, high frequency, combining eccentric training. Why? I think this is addressing the rotator cuff. Small muscles, low intensity, high frequency, eccentric. When you throw, the muscles have got the eccentric lengthening. I think Simon talked about the eccentric part, eccentric phase of the exercise. Eccentric, 即係離心性動作啦 ，OK？ So eccentric phase during your throwing, the deceleration part relies heavily on eccentric control of the muscles. How about rotator cuff tendinopathy? Again, these are all meta-analysis, meaning that they pull in a lot of studies and examine the effectiveness of treatment for rotator cuff tendinopathy, and also supportive of the use of exercise in the treatment of rotator cuff tendinopathy. Generally, they will be able to see some clinically significant outcomes by 12 weeks. And exercise usually suggested with resistance, high repetitions, and around 3 sets. If you're interested, I guess for physio students, if you're interested, you can look at this particular study. This is quite a good one to read. It's a good, easy read. Okay, Simon has talked about quite a lot about the initial phase of the injury for hamstring. But for me, I guess more, I like to talk about exercise rehabilitation, because I think in general, most people, like if they go to physio, 好痛啊, okay, and then they do some modalities, they have some manual therapy being done. 但係做完晒之後係舒服啲, but the athlete cannot return back to play. That's the most important thing. You're not getting them back to sports. So when can we start shoulder exercise rehabilitation? I'm not saying that those modalities at the initial phase is not important, because if pain is predominant, that's what you want to work at. Okay, when can we start? When the primary presenting symptom of the shoulder pain during activity with minimal pain at rest. 即係話喺佢at the resting position is not painful anymore. There's no significant loss of passive range of movement. That means the joint can move rather freely now. There's no symptoms of shoulder instability when the acute phase has passed. So at that particular stage, if your athlete is at that particular stage, then active exercise therapy is the main way to treat your patient. Okay, there's strong evidence to suggest that the active exercise reduce pain and restore function with shoulder pain. What are the general principles? Just now we talked about the importance of the scapular plane for scapulohumeral coordination. So that's important. You work it in a gradual manner in alignment. You avoid any abnormal compensatory trunk movement, and then you load the joint as it is able. If you are I think there's some strength and conditioning coaches in here. You can't load the joint when it is in pain, so you need to load it with a pain-free range and then progress it as able. Mobility is the product of both flexibility and end range. Okay, meaning that if the physio students as well too, if you work on your athletes or your patients, passive range, you restore the range of movement. So it was restricted in here, you restore it up to here. But if the patient has not got the active control at this part of the range, this is still quite useless. So the control is by muscles, right? Passively, you need physio to help you to work on the joint range. But towards the end, you need physio to work on the exercises, okay? To get the product that at the end range of the movement, you're able to gain the control. Okay, so exercise should not provoke the pain that the athlete presented with. On a scale, on a visual analog scale, or when you ask the patient out of 10, anything less than 4 usually okay if it's due to the effort of doing the exercise, not the pain that the athlete complains about. Okay, that they say, there's some pain involved, but it's just because of the effort of the exercise, and then it needs to subside within 12 hours. My general way of asking my athlete is, they've done their exercise. If it feels a bit hot and swollen, they may put ice over the area just to let it be more comfortable. The next morning, when they wake up, if there's still a lot of pain, you're doing too much. Okay, the next morning usually is the guideline. And if it's swollen, I guess swelling in the shoulder, not so much to see. But for instance, if you're working on the knee, after you've done the exercises, it may swell up a bit. That's still okay. Ice it. Rest it for 8 hours overnight. Next day, moves quite easily. The swelling has gone after 8 hours rest. That is okay. But if still continues to swell up, that means you're doing too much. Okay? So the quality of the exercise is important. Why is it important? Because we talk about the scapular plane. If you're putting it into the wrong position, then obviously you're not working it properly. General principles of how to progress the exercise. You start off with unloading, then you load it. Simple exercise with a single plane, and then you work at more complex movement. Start from slow, gradually to faster speed. You work the exercise in a conscious manner first and gradually decreasing your feedback, and then it becomes an automatic thing. The number of sets of exercise usually around 3 to 4 sets. Okay, so I want to finish this part.
好，多謝晒 Ella 嘅分享，相信大家都明白多咗啦，唔同嘅階段嘅一啲 rehabilitation 同埋 strengthening 嘅 skills 嘅。咁啦，而家會進行問答嘅環節啦。咁台下會唔會有參加者想舉手發問嘅？咁我哋同事會帶咪俾你嘅。好，如果暫時冇嘅話都唔緊要。有，好，麻煩同事呢度綠色衫呢位女士，唔該晒。
我係潛水總會，我想問一問咧，我係潛水總會，我姓朱嘅。我有一個 athlete 咧，成日咧都甩臼嘅。咁但係咧，佢主要係游自由式嘅時候甩臼。咁甩咗之後咧，佢又應該嗰段時間好翻，佢又繼續游完之後咧，佢又甩臼。咁我諗呢啲係咪一個好經常
？Obviously, recurrent shoulder dislocation is not a good thing for the athlete. Definitely, you don't want that to happen a lot. There are a couple of things that may lead to the recurrent shoulder dislocation. Firstly, the pathology itself. As I mentioned, if you have a simple shoulder dislocation, if you strengthen the muscles around it, you should be able to prevent that from happening. But if the shoulder dislocation is one of traumatic, where you got a change to the structure, like the heel sash lesion I mentioned, where there's a bone depression and then the space of the ball and socket is bigger and it moves a lot more, it can be an issue. So those, if they continue to have the recurrent shoulder dislocation, some athletes may eventually need surgery. But the second thing is the modifiable factors, which are the dynamic things, the muscles surrounding the shoulder joint. Whether you should be able to strengthen it, or maybe the strengthening program or the exercise rehab phase after dislocation is not worked on properly, is not strengthened enough. If you're doing just freestyle, that shouldn't be a problem. I can't imagine that is a problem. But I can tell you, I can share with you an experience of one of the patients that I have seen. He's a volleyball player. 我點解會有呢個patient 呢? I do some teaching at last year with the MSc and Manip therapy group, teaching them about exercise therapy for shoulder. One of the students, who's a physio, I don't know why she's not treating her brother. She sent her brother to us for physio. Her brother had a shoulder dislocation many years ago, 15 years ago. He might have gone through some rehabilitation work. So at that time when he presented to us, he was playing volleyball with friends, and it was just a matter of the ball hitting and the hand goes like this. The shoulder got dislocated again. So I don't think that dislocation is it's not a traumatic incident that goes like this. It's obviously the muscles are not strong enough to protect. So eventually we went through a full program with him. He returned back to play with no issues at all. So I mean, I don't know, whether your athlete has got MRI taken, whether there are some structural issues. The other thing is you need to train the muscles very, very hard. That's probably what is needed.
I think so.
Yeah.
I think so.
Okay.
好，唔該晒 Ella 嘅回應。咁我手頭上仲有兩條參加者喺 slide 上嘅問題啦，咁麻煩同時都 pass 俾Ella。咁我而家都講一講第一條問題，就係 Poor core may lead to incorrect muscle activation sequence during overhead throw. Is it a must to train core before rotator cuff strengthening to avoid injuries or training wrong muscles？ 唔該 Ella。
係，我睇下先。Poor core lead to incorrect. Is it a must to train core before rotator cuff? I don't think there's a sequence whether you train rotator cuff first or train core. I think core is part of your training program. That means that if you have a player doing overhead activities, don't only just think about training the shoulder complex. The core part is important. My message is purely saying that if you are doing overhead activities, the core muscles are one of the integral part that helps to stabilize or prevent the arm going into position or not stabilizing enough because the core muscles are not strong enough. So there's no sequential or preferential activation, one or the other, but actually is part of the training program. I think that's what I mean. Okay.
好，唔該晒 Ella 嘅回應。咁第二條問題就係 What are some signs that indicate progress during shoulder rehabilitation, and how can setbacks be managed? 唔該 Ella。
Okay, signs for progress. I think if you coaches, you will know if the exercises are getting easier, then obviously you need to progress. And often, I think I already have a slide that showed you can start off with simple one plane exercise and gradually move to more complex. Even if you do, for instance, if you're working in external rotation at 90 degrees abduction in this range, a lot of people have difficulty doing this because it's painful. So you can progress starting in here, starting in here, some scapular plane, and then gradually working back, gradually working up here. So you progress it according to the players' subjective or perception about the exercises, whether they are too easy or not. And then you also watch the way how they do the exercise. Sometimes when they first started the exercise, they didn't master well. But as you continue to work on, if they find it easy, I think you need to continue to progress it. The setbacks are, if they have pain, then I think that you need to change the exercises accordingly. I think I mentioned it. During the exercise, if it reproduces the patient's pain, or maybe the next day they're not recovered well, then you may need to just go down a bit. There are many exercises that you can do. Okay, I mean, they are core, they are lower limb. So in a session that I work with the athletes, we don't all do shoulder. We'll do some hardcore things with the shoulder. We change to something else, give the shoulder a bit of a rest. Because if you're thinking about doing stability, if the muscles are very tired, you can't actually get very good execution of the muscles. Okay?
好，多謝晒 Ella 嘅回應。台下仲會唔會有其他嘅問題呢？好，如果冇嘅話咧，咁請大家再一次俾啲掌聲 Ella 嘅。咁啦，請 Ella 留步。咁啦，而家致送感謝狀俾 Ella 嘅。好，咁啊，請兩位移步到台下。咁咧，而家係小休時間啦。咁因為時間嘅關係咧，咁大家有5分鐘嘅小休時間嘅。咁5分鐘之後咧，麻煩大家翻嚟呢度，我哋會進行第3個環節嘅。唔該晒大家。